call the Board of Health meeting, May 22nd, 2024, to order. And we're going to do member roll call. And we'll start with Ted Collis, and he's excused absence. He's out of town. And I'm here. Commissioner Cammie Brimmer. Absent. Dr. Deborah Chan.
Present.
General Jack Briggs.
Present.
Councilman Dave Donaldson.
Here.
Commissioner Lojinas Gonzalez.
Here.
Mayor Glant Havenar. Absent. Dr. Richard Vu.
I'm here.
Thank you. So we do have a quorum. May I have approval for the agenda?
I move to approve the agenda.
May I have a
Commissioner
second?
Briggs. Second.
Okay. General Briggs seconded. All in favor?
Aye.
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 Okay, now for Board of Health comments, and I'm going to start. I'll just say that to me it was disturbing to read in the Gazette about the needle exchange program that's in our community, and that our Board of Health was not made aware of this, and for many years. And I sat on the board the last time that that was brought before us, and it did not pass. It wasn't unanimous, but it did not pass. And I know that the state legislature passed a bill that said that any hospital or medical facility or a nonprofit that had experience in this could set those up. I think it was an omission and not very transparent, and I don't think it's I don't know why CDPHE felt like they had to set up kiosks in our community for us, and I don't know who's filling those for them, because I don't have enough information. But to me, it's very upsetting, and I just want to bring that it's to your attention, and would appreciate any other Board of Health comments. I'd like to learn more and get more information as we go along. Thank you.
Madam Vice, can I add to that? I was very disturbed. I found out about this maybe 2 weeks ago. I was just following up, doing research on the Pueblo. City Council was looking into their local issues regarding this, and I started seeing links to Colorado Springs Needle Exchange as I was looking up the same thing for Pueblo. And what I found was that even on the CDPHE website, they are advertising that these are happening in Colorado Springs. I went to the links locally, indicating the exact same thing. I started inquiring. I sent a CORA to CDPHE. CDPHE indicated that to the CORA response that they had no communications, emails, documentation from the organizations here in regards to either wanting to start needle exchange or stakeholder meetings. I found that interesting. I replied to the CORA as well as the director, Director Hunsaker Ryan, asking a very simple question. If you have no documentation or emails or communications, why would you have added them to your website? They took a few days, but did respond back saying that a lengthy email from Dr. Ryan indicating that they had discussions with the local organization, and in light of their experience were added. I think it's very important that Dr. Ryan indicated based on the experience of the organization, which means it falls not under medical facilities licensed by the state, but as a nonprofit with experience in needle exchanges, because the guidance is very clear. As you mentioned, the legislature changed the law in 2020. I'll be very honest, they changed the law because of this Board of Health not wanting and rejecting needle exchanges, but they left in place a very significant stipulation in the law. The revised law stated prior to operating that those nonprofits must, or the word is shall, which shall in legal terms, and my lawyer can confirm this, shall means they must conduct stakeholder meetings, and in reference to as per subsection 1 of the state statute. Subsection 1 defines stakeholders, and within that it includes local law enforcement. It also includes DAs, district attorneys. Very specific question, as was in the article. Our local district attorney has stated on the record he was not involved in any of those. So my assertion is that these needle exchanges are operating outside of the law and in violation of state statute, the revised state statute. I believe if they are in violation of the state statute on needle exchanges, then they are also in potential violation of the state drug paraphernalia law. So I have sent an email to the mayor over a week ago of Colorado Springs, asking him to look into this. I think this board should, we have no authorities, but I think we as a board could perhaps send a letter to the mayor of Colorado Springs and the police chief, asking that he enforce the law. Thank you.
Yes, thank you. As many of you know, I've spoken out about safe injection sites and needle exchanges before, and I'll give you the at least the ground view practitioners' view of this, while the council members and elected officials have a different sort of angle on it. Because what we see every day at the rescue mission in terms of addicted individuals is that they will come to the rescue mission and they will have 20, 30 needles when they show up. Not everybody, but when they do, they'll have these needles. And we won't let them bring all of those needles in. They may have a medical condition such as diabetes or something like that where they need those, but we won't let them bring them all in because what they're most likely going to try to do is try to sell them while they're inside the facility. So there needs to be some professional evaluation of this in the county and in the city with healthcare providers to try to understand better how to do this. There are some valuable things to something like this to help with the spread of HIV, hepatitis, those sorts of communicable diseases. So I'm not saying let's throw the baby out with the bathwater, but I do think that there's something about medical supervision of some kind to facilitate this in a much more organized way than just kind of a free-for-all. And it's not an exchange. You know, a needle exchange would be, I have a needle, I don't want this needle anymore, I need a new needle. When you can turn in a needle and get 10 needles, that's not an exchange. So, you know, I think that there's something that needs to be done about this for the community itself. We see, at least publicly, people complain about the needles along bike paths and, in front of the rescue mission. We see a lot of them every morning. So there's something to this than just this benign idea of exchanging needles just in and of itself. Thank you.
Madam Vice, could I add one other thing I forgot to mention and what was brought up here? What also greatly concerned me in my emails back and forth with the director of CDPHE, I did receive a response from the state's medical director, Dr. Kalonge, where he stated that CDPHE, the law does not give CDPHE the authority to regulate or investigate syringe access program operations. What greatly concerns me, it has now been past a week since I asked CDPHE, both the director and the doctor, if you're not in charge of regulating or investigating, please provide me the department that does and their contact information. I've been waiting a week for any notification from the state on who may or might not even have regulatory or investigation authorities over needle exchanges. Because until I receive that information, I'm under the working assumption that the CDPHE either doesn't know or there isn't any. Thank you.
Thank you. Any other comments? Councilman Donaldson?
Yeah, thanks. Is this on? Is it on? Thanks, Madam Vice Chair, and I want to thank Commissioner Gonzalez for being the one to discover this. And I'll say, you know, I'll speak for myself on City Council. I had no idea this was going on, and it is frustrating and disturbing if it was sort of done as an end run around this Board of Health and brought into the city. And I do receive complaints from citizens about needles at bus stops, playgrounds, and other places in the city, and citizens are concerned about it. So I don't believe City Council will ignore this. I've asked our staff to look at the Pueblo ordinance and sort of start to talk to our attorneys, see how we could do something like that here, if that's the direction that council wants to go. And the most frustrating part about this is there was no notification up front, and it has been going on, and we haven't been aware of it. And I don't think we should reward that kind of introduction of things into our city by ignoring it. So, thanks.
Thank you. Any other comments? Dr. Chan?
Yes, I'd like to second what General Briggs was saying. I was not aware that this program allowed people to walk away with dozens of syringes. And as we all know, harm reduction needle exchanges were started during the HIV pandemic when owning a syringe required a prescription, and otherwise owning a syringe was considered drug paraphernalia and therefore illegal. But now people can access syringes more easily, and one of the harm reduction aspects of needle exchanges was that every contact with the needle exchange was an opportunity to get people into treatment. So I think that obviously if somebody walks away with 20 or 30 syringes, you're giving up that possibility of repeated contacts. And so I do think that if this is something that's going to be considered by the stakeholders, that some sort of parameters need to be discussed about, first of all, the difference between syringe handouts and an actual needle exchange that is targeted towards harm reduction.
General Briggs?
So I'm not going to try to do math in public here, but I can't tell you that like they give in one syringe and then 30 come back. I can tell you that they bring that many, right? So it may be multiple trips to try to get them over time so that they would, maybe get 5 or something. So I'm not saying that the providers are just dumping them, but there is no in-game regulation on how many they can end up with.
Thank you. Any other comments or questions? Dr. Vu?
Dr. Chen, you mentioned harm reduction, and I just Googled needle exchange services in Colorado Springs, Colorado Health Network, and the headline is harm reduction services. In my mind, I don't understand how it can be a harm reduction service, although I really don't know because I don't know the data. In my mind, there's more harm in a needle exchange program than benefit, but that's an opinion. So I was wondering if there's a way that we can get some good data to see if these are truly harm reduction services or not. We can argue that it can be, and we can argue that it cannot be, but I can't imagine that, we are that it is truly a harm reduction service.
Thank you. General Briggs?
Yes. So Dr. Vu, I can tell you that having done a lot of research on this because of our clients, the data is going to be what you want it to say. So if you want to say harm reduction in the sense of communicable disease, that there's a path on that, right? Which I think has some good longitudinal data on it. So I'm not trying to throw the baby out with the bathwater on this, but what won't be discussed in that data is the continued use of these controlled substances, to include fentanyl, that will have another effect, right? You're robbing Peter to pay Paul on this. And that's where we need to understand this better so that we can make a community decision that's part of what this board's mandate is, which is public health overall, as opposed to, and again, I agree with you, just screaming at the top of our lungs or into a well that we don't like needle exchange, that's not the thing. It's what's the right policy for this community's health and how to do that the best way, I believe.
Thank you, General Briggs. I agree with you. You're talking about the strength of the data, the reliability of the data, and the validity of the data. What are we measuring? What are we wanting to see? But at least if we have some data, even though it might be weak data or even bad data, it'll be good to see and discuss that.
Director Whelan, do you have any comments?
For clarity, our agency doesn't have any involvement in this, this effort. So when we're being asked for data specifically on the organization's efforts, that has to come from the organization. Now, if you want other types of data, then that's an area that, we can provide. And we just released our community health assessment that I wanted to showcase today. But I wanted to provide that clarity. I'm happy to do whatever the board would like, but if you're asking for data, that has to come from the organization. And I don't know the volume of what their operating looks like. I don't know any details about this operation.
I do think that asking the organization for data might not give us a very clear picture, because as the general is saying, sometimes the data will say what you want it to say. And if the organization is operating a needle exchange program, they're not going to have the counterfactual. So I think that it's very hard to draw any conclusions from information that they provide. Also, again, I'm not an addiction expert. I had some experience with drug crises, during the crack epidemic and now during the opioid epidemic. But I think that a lot of the studies regarding harm reduction in terms of transmission of communicable diseases were made at a time when getting a needle was very, very difficult. And so there was rampant needle sharing. Whether that is as much of an issue today is hard for me to say, because I don't know. But I think that it probably takes, we probably should take a closer look at it. And then when it comes to harm reduction, we probably do need to take a closer look at what the organization is saying and what their view and their data and their counterfactual would show.
I did want to add also is when in the realm of harm reduction, the idea is to capture the client, to have that interaction, to seek some intervention related to counseling. And I don't know this operation as it relates to what model they're using, what the different aspects are. I mean, I'd be happy to reach out to them and see if they'd be willing to provide a presentation to the, to you all. But I don't have detailed information on this operation, as the legislation had changed and it was set in state statute to not provide the local boards of health the authority to approve the syringe exchange programs. Therefore, I have not been involved. Our agency has not been involved with this operation.
Susan, Director Whelan, were you aware of it? I guess that would be my question. I know that Deanne Ryberg has served or serves on the Community Health Partnership, and from the article that was in the Gazette, it looked like that they referenced that as one of the organizations that they spoke with, and was just curious if it was just.
I was aware of the legislation that was moving forward a few years ago. However, as far as the Community Health Partnership, we have had in the last few years with the pandemic, our participation on certain boards has not been consistent, and we have had our medical director, a previous medical director, on the Community Health Partnership Board, and I'm not sure if it was discussed during that time. I became aware, and when Commissioner Gonzalez had reached out to me.
Okay, thank you. Okay, Dr. Vu?
So I just got on Amazon, and $5.99 for 10 packs of needles and syringes, $9.99 for 20 packs. So these are accessible. I don't know, from my standpoint, if someone if an entity were to put up a program that is promoted for harm reduction for the public, and I myself don't agree with that, then either I myself need to prove that they are wrong, or I'd like to see data from them to say that they are right, and then we can have a discussion.
Madam Vice, and so what I would say, I absolutely agree with that. The law says they were supposed to conduct these stakeholder meetings prior to operating. And so if we want to have meetings and do information, that's great for public knowledge to understand. But the basics are, I believe that this organization is operating outside of its legal authorities, as stated very specifically in state statute. If they are in violation of the law, then what is being done? This board has nothing to do with that. So again, that is why I sent an email to the mayor a week ago asking to investigate this. And I will again reiterate, this is, from what I can tell, falls under the city of Colorado Springs. Law enforcement falls under the police chief. I am asking that the law be enforced. If they are in violation of the law, they need to be stopped from conducting these until they are in compliance with the law, which is their requirement to hold stakeholder meetings with the required individuals as defined in the state statute of who those stakeholders are. Thank you.
Thank you. Okay, I think we'll move on, unless there are any other questions or comments. Councilman Donaldson?
If I could
Okay.
add one thing to what was just said, the last two comments. It may be that people can buy needles through Amazon, but if organizations are distributing them here in the city and they're being left in parks and playgrounds and other places, it may be appropriate to regulate that. City council and mayor, and it's not the chief of police who's charged with enforcing our laws by our charter, it is the mayor. It's the mayor's responsibility to enforce the laws. He uses the chief of police to do that, but goes back to the person you sent the email to. Thanks.
Thank you. Okay, so approval of the minutes of the April 24th Board of Health meeting. Can I have a motion to approve?
Briggs, I motion to approve the minutes as written.
Okay, second?
Second, Councilman Donaldson.
Okay, all in favor?
Aye.
Aye.
Any opposed? Thank you. Okay, so are there any public comments not on the agenda from the public, from items? No? Okay. Thank you. So, okay. So something that we're going to do today is we have a proclamation recognizing May as Mental Health Awareness Month, and I'm going to read the proclamation. Effective date, May 22nd, 2024, proclamation of the El Paso County Board of Health recognizing May as Mental Health Awareness Month. Whereas the month of May is nationally recognized as Mental Health Awareness Month, a time used to raise awareness about the importance of mental health. And whereas addressing mental health is paramount to improving overall community health, as state and local data sources demonstrate the continued need to focus on mental health and access to mental health services. And whereas in 2021, 25% of adult Coloradans over the age of 18 reported having a mental illness in the past year. In 2019 and 2021, combined 19.5% of El Paso County residents reported 8 or more days of poor mental health in the past 30 days, and 42.4% did not get needed mental health services because they had a hard time getting a mental health appointment. And whereas El Paso County Public Health recognizes that continued efforts and collaboration with community partners is important to combat mental health stigma, increase access to mental health services, and promote overall mental wellness. And whereas mental and behavioral health services as the overarching framework for the El Paso County Community Health Assessment, which identifies the leading local health issues that then inform the development of the Community Health Improvement Plan. And whereas the 2024-2028 Community Health Improvement Plan provides the framework and strategies to support meaningful improvement to the overall health and well-being of El Paso County residents, which is made possible through community engagement and partnership. And whereas El Paso County Public Health, the local behavioral health community, and local partners are collaborating to improve mental and behavioral health outcomes through an innovative behavioral health resource that will promote mental health awareness as well as provide preventive measures, early intervention, self-care, and screening, which supports individuals in developing habits that will help them learn how to cope and adapt to mental health issues. And whereas El Paso County Public Health will continue to provide behavioral health programs and services to support ongoing efforts around behavioral needs in the community, which include youth suicide prevention, care coordination, trauma-responsive training, crisis counseling, and disaster coordination, community-led mental health work groups, mental health screening, substance use prevention, internal staff mental health training, and tobacco cessation supports. And whereas El Paso County Public Health encourages all residents to support mental health initiatives by fostering a sense of connectedness within their communities, engaging in education and awareness activities, and advocating for resources and policies that prioritize mental health. Now therefore, be it resolved that the El Paso County Board of Health recognizes May 2024 as Mental Health Awareness Month. Moved, seconded, and adopted by the El Paso County Board of Health at its meeting held May 22nd, 2024 in Colorado Springs, Colorado. Do I have a motion to approve this?
Move to approve?
A second?
Second, Briggs.
All in favor?
Aye.
Aye.
Aye. Any opposed? Okay, motion passed. Thank you.
Madam Vice Chair,
Yes,
can I make a comment?
sure.
So from my military experience and then my current role, I'm highly encouraged by seeing the attendance today with those professionals that are involved in this on a day-to-day basis. We have elevated the awareness of mental health as a community and as just a nation to a place where we're getting better at it. And that's done by those folks that are represented in the room today. And I'm grateful for you, what you do every day for this, seeing it firsthand. We have a bit of catastrophic success here in that as we've raised awareness, we have not been able to keep up with the clinicians and those that can help individuals. That's something that I think as a society we need to consider more. But I do want to say that this community has shaken off some of those old stereotypes about what mental health can be and has started down a path that I think is very healthy for the whole community. So thank you.
I'd also like to mention that Colorado Crisis Services hotline number is 1-844-493-TALK, or text TALK to 38255, which is a great resource if someone is going through a crisis or someone knows of someone going through a crisis on how to get some help. Okay, Susan?
As General Briggs, you said that we're grateful for a number of our partners that are here today, and that's only a snapshot of the many partners that we have across the Pikes Peak region. I'd like to ask that Mayor's wife, Abby Mobilati, come up and say a few words, and then I also like to invite other partners in the community to come up and say a few words about the work that is being done. And I will say that I'm incredibly grateful for the partnerships, and we have strengthened relationships with the City of Colorado Springs, with Abby Mobilati. She's done a lot of work to strengthen the already good work going on and bringing numerous different partners to the table and consistently to seize opportunities for increased action and to strengthen and lift up our efforts. As you all know, the work on whether it's suicide prevention or mental health, it can be difficult at times. It can be very heart-wrenching, especially when loved ones are lost and we experience these tragedies in our community. And so I, again, am incredibly grateful for Abby Mobilati and have really enjoyed working with the City of Colorado Springs, and we're going to expand out to different municipalities. But we can say a little bit about what our efforts have been to increase mental health awareness and reduce barriers to accessing care.
Thank you, Susan.
Is it on?
Good, thank you. First, I just want to say thank you for allowing me some time and some space to speak this morning. I appreciate it. I do believe that Jack Briggs has already kind of said everything that I wanted to say and needed to say, so thank you. Yeah, you stole my thunder. I'm just kidding. But I, one, feel very honored and grateful for the partnerships and that y'all have allowed me to kind of step into this space with you and come alongside and champion what you guys are already doing. So thank you for that. It really is my honor and my pleasure, so thank you. What we are doing as a city and as a community in Colorado Springs is really just emphasizing that collaboration, that partnership, really making sure anybody that needs and wants a seat at the table has a seat there. And as we pull more people in, we realize other seats that need to be added, and we are grateful and willing to do that. And here today, you can see just a smattering of that partnership. I would like to say Thomas Thompson is here. He is the mayor's special liaison, and he has been invaluable with this effort with the city. So I'm like the face, but really Thomas is doing so much work. So thank you, Thomas, for everything that you have done. David Lineweber, who has been championing this for the city everywhere he's going, talking about it, and really putting that out there with the opportunity that he has. We have the police department and the fire department. We have children's here. We have NAMI. We have Pikes Peak suicide prevention. We have Dr. Charles Benight, who is doing amazing things at UCCS that I'm telling everybody about, just so you know. So get ready. And I'm missing people. Diversis is here. Peak Vista. So really, I'm very proud of the people that have been willing and excited to come to the table and start working on this as collaborative partnerships, and really working together as a community and as a city to start addressing some of these needs. So it is my honor and my privilege, and I feel like this is just the very beginning, and there are really exciting things on the horizon. I'll let you talk about what we're doing right now. I'm not going to steal his thunder. But I mean, really and truly, I'm so proud. I'm so proud to be in this city. I'm proud to be a citizen, and that I get to stand in rooms like this and talk about things that really matter. So thank you for your time, and thank you for your partnership. I appreciate it.
And Abby, I'd like to say thank you for taking on this initiative. It's huge, as we all know, and it sometimes I know seems overwhelming, but we have to take that first step, so thank you so much.
It is incredibly overwhelming. Yes. You start to poke at it, and you're just like, oh, this is a really big problem. But the good news is we have so many people in this city that have already been doing the work for a very long time. And so we have a really strong foundation that is ready for us to really make some progress and really make some forward movement. So I feel like I should be talking to you guys, but really and truly, everybody that has already been doing this work, just steal my husband's line, I see you. We see you. And it is hard work. It is meaningful work. It often goes unnoticed and unappreciated. But we see you. The city is going to see you. And thank you.
Thank you. And we do have a number of different partners that would like to say a few words. Not everyone needs to speak, but I know that some of you do want to have a little bit of time to say a few words. So please come on right up. One would run right after the other, please.
Yeah, I'm really excited to be here and really put forth some of the thoughts and efforts that the city's been kind of working on in partnership. Abby's been a great partner, and yes, Thomas is amazing. Thank you. When I kind of dove into this issue, or actually when I got on city council, the primary reason I am on city council is because mental health was not one of our top 4 issues in our city, and it should have been number 1. We all know the statistics. It's been over over a decade that we've been number one in suicide. And we haven't really, we haven't in the past really addressed it in a very serious way. And I believe that is changing. I believe more and more attention is really being brought to the table. One of the first things I heard is we need to hire more professionals. And Jack, I totally agree with you that that is an absolute truth. But I don't believe we can hire enough professionals. That will never be a solution. And so that created an idea that I just loved the way that it kind of unfolded. At the first listening session with the mayor, I had this idea of, hey, Mayor, what do you think about doing 1,000 block parties? And he said, done. He got up on stage. He got up on stage and announced it from stage before any of his staff even knew about it. Because it just makes sense. Human connection is really the key thing. When you look at physical health, we look at the complexity of physical health and all the different aspects of that, and we look at the ways we talk about excellent health or poor health. But often we don't kind of use the same language for mental health. And it is very diverse, it is very broad, and it is very complex. And what's fundamentally different about mental health is that human connection is key. And in getting our communities to engage with one another, to create that human connection, I think is vital. So we have launched this 1,000 neighborhood block party, or 1,000 neighborhood gatherings. I said it, sorry. We had to rework the name a little bit. Excited to report that we're registering. How many have signed up? We launched it last weekend. We got the attention of the governor, and the governor came down and went to several of these initial parties that we're going to have, or gatherings we're going to have throughout the summer. And we are at 129 have already registered, and we've just begun. So we're really excited that we're more than 1/10 of the way there, and we're just at the very, very beginning. And I would encourage everyone in this room to consider hosting and doing a simple event of just getting your neighbors together and get to know them. It's that easy. I think the next initiatives that we're going to be looking at are probably that of this idea of providing a third place, something to kind of look into, a place where people can develop and learn how to be themselves outside of the contract of family or job, and how can we foster and grow those things. So those are some efforts that the city's kind of working on, and we always appreciate your support and effort, and thank you for all the hard work you guys are actually working on.
Thank you.
Madam Chair,
Yes.
I just want to state for the record that that was David Lineweber from Colorado Springs City Council, and if we could have other speakers please introduce themselves, I'd appreciate it.
Going to have to move this down a little bit. A lot, actually. Good morning. I'm Mary Rosenoff. I'm Deputy Chief of Police over the Patrol Bureau. It's very fitting that we're both up here together. I'll let Jamie speak for herself. I always let people know that I have 3 families, the one I was born into, the one I was called to, and the one that I serve, which is community. But I'm also a community member myself. Very proud of all of the people here that have embraced our community response teams. Very thankful for that. A police officer started that in 2014. It involves a police officer, a firefighter, a paramedic, and a clinician. And from 2014 to 2020, we increased those teams to 4. That is wonderful, but it also means that there is a need, and we are continuing to respond to that need in terms of crisis and people that need services rather than just law enforcement. That doesn't always work. When we go on a call for service and that person has a need, it's finally nice that we have educated ourselves so that we can present, whether it's El Paso County Health or if it is suicide crisis line, that we have another outlet for those people and the services so that they can be sustainable and continue. So I thank all of you here for the opportunity and also all of you in the audience that have collaborated with the Colorado Springs Police Department.
Good morning, Jamie McConaughey. I am Deputy Chief of Emergency Medical Services for the Fire Department. And I'm just going to piggyback off of what Mary has shared. In 2012, we started our Community and Public Health Division in our fire department. And that was an effort to try to understand issues that were affecting the 911 system. And that division stood up predominantly medical in nature. And what we very quickly learned is that there was a much stronger mental health impact and behavioral health impact on our community. And so from 2012 into today, where we have 30 members in our division, more than 2/3 are behavioral health professionals. And that's really important because we've adapted what we thought into what the needs are, and that's really what that's about. I keep hearing collaboration and partnership, and those are very, very important words. And they're words that have driven the success of what we've been able to do in our community, because quite obviously, we cannot do it alone. We as the fire department or we as the police department do not have all the answers. So we find those answers through collaboration. I want to highlight the county health department. So in 2012, we received a sub-grant through them, through the CDC, to be able to stand up our transitional assistance program. So that program works specifically in the jail system. It works on recidivism. And what that means is we have the ability within the jail system to hand off to teams in the streets that help try to alleviate the issue of returning to homelessness, of substance abuse, and of mental health. So those have been very impactful teams within our community, and we couldn't do it alone. So we learned so much by partnering together. And also one other thing I want to highlight that's really important for both of us too has to do with the mental health of our first responders. So I want to give a shout out to Dr. Chip Knight because he was instrumental for the fire department learning all the way back to 2004 how important the mental health aspect of the work that we do for our community is. We engaged in a study with UCCS, and Dr. Chip Knight helped us navigate what that looked like for our department. They provided trauma treatment services for our individuals, and really what ultimately happened is they helped change the culture of our department and our departments. So it is very much okay to not be okay. And that is a message that I think needs to be shared everywhere and broadly. Finally, I'd just like to thank everybody on the board because your roles are very important to our community. Your time and your talent and your wisdom that you provide to ensure, a safe environment for our citizens and a healthy environment. I just want to thank you for that. Thank you.
Thank you. Any questions or comments from the board here? No? Dr. Vu?
Thank you. There's so many mental health entities in the same room at this time. I have one opinion and maybe one question. So I'm a primary care physician. I myself do not think mental health is separate and different from physical health. I think both coexist and one affects the other. I think that 100% of my patients have some level of physical health issues, even if their physical health status is healthy. And similarly, 100% of my patients have mental health issues, even if that status is healthy and need to be maintained. So I wanted to express that opinion. Question is, I understand that there's lack of access to mental health, behavioral health services. So the question is, why do we think that is? I have heard many answers to that, but I wanted to talk about it just a little bit, not too much. That's a big topic. And what's some of our opinions here of what we can do to improve that access? And I don't know if I'm asking that to any specific person here.
Abby,
Yes,
would
thank
anyone
you.
on your team like to address that?
Well, I think that that's probably a perfect segue into our community health assessment because we have the data in there, and one of the priorities for our agency is to increase access, and it's framed a little bit differently to reduce the barriers to access. And we're not only talking about healthcare, but we're also talking about mental health services. And so we have our public health planner, if you wanted to say a little bit more in detail, or we can provide some more of the data. But I think it's varied depending on what population we're talking about. So I see that we have a representative from Children's Hospital, and General Briggs had talked about we're doing a better job of destigmatizing the need to, for mental health and to increase help-seeking behavior. Back in 2014, when we started the Teen Suicide Prevention Work Group, one of our priorities was to increase help-seeking behavior. And so if you have efforts as it relates to, hey, it's okay, like it's a strength to reach out to get help, then they're going to reach help. So when there's challenges as it relates to providers and easy access and getting in, we know that we do have a shortage of providers. So that's one aspect, and we can tailor this to different organizations. We have Peak Vista here, which has challenges as it relates to different increasing access. But I also think that the capacity within the community as it relates to the toll that has been taken within the last few years, and with different populations, and what is being practiced as it relates to if it works for you to get into mental health services. Also, there are certain things that we can all do, whether it's taking a walk outside, or texting a friend, or checking in, having a neighborhood gathering. And so we're trying to attack this from many different areas. But when you say what are the what is the problem to access to care, I think it's going to be very complex, and there's a lot of different it's multifaceted.
Thank you. I guess maybe along the same line, maybe I can ask a more focused question. Do we think low reimbursement is a major contributor to lack of mental health services access?
So that has been brought up in the collaborations that I'm part of, yes, and from many different health providers.
Thank you.
Thank you. Okay, next.
I think I'm the shortest probably so far. Good morning. I'm Lauren Eckhart. I'm the clinical director at Children's Hospital Colorado, Colorado Springs. I am a child and adolescent psychologist by training. I have been in this community for over 10 years, so I'm really excited to be able to be here today, particularly to represent children, as I think that we're kind of the new kids on the block when it comes to mental health care here in Colorado Springs. The agencies behind me that have been doing this for decades have done a tremendous amount of work, and we've been largely absent. Our efforts really started in 2019 when the hospital was built, and in the hospital, in our emergency room, we have a 6-bed psychiatric emergency department. It was the first in the state. We are 3 times the size of our own department in Anschutz right now. So that was visionary on children's part, and at that same time, we also began plans to open behavioral health services. That was May of 2019. Everyone knows what came next, so that did not unfortunately happen until the fall of 2022, when we were able to open outpatient services here in Colorado Springs, both for our general behavioral health populations, but also in an integrated setting, Dr. Vu, to your point. So I have 6 psychologists embedded into medical specialty care clinics over at Briargate. And really, what I'm most proud of is the growth of our team and how that has enabled us to increase access. You shared some stats when you read the proclamation about 1 in 5 adults. This is actually a weird situation that it's the same number for kids. 1 in 5 kids are currently struggling with a mental health diagnosis, and only 50% of them are likely to get help. Suicide is the first leading cause of death for children ages 10 to 19. So I think that very clearly indicates that we have a big problem. And members of this community that have been here and been doing this for so long, our efforts, as we said, in some ways go unnoticed, but in some ways do not. And unfortunately, El Paso continues to lead the state in terms of our teen suicide rate. So really the hope here today and the honor here today to hear the community coming together and to back this proclamation, is we're all here poised to kind of fill in a very unique gaps that each of our agencies can do. And my hope is that we can continue to work towards a really full and seamless continuum of care, where folks don't have to feel like they don't know where to go, or they don't know who to turn to, or they don't know how to ask for help. I don't want that number to be only 50%. You know, I want to see it at 100. But we have to have access, we have to have workforce, we have to have parity, we have to have all of those things. And I think with all of these teams and agencies represented in this room, we have a really tremendous opportunity to begin some of that work and to really impact our children, who are going to be the ones that are sitting here 10, 15, 20 years from now. And yes, they're very well poised, they're much more likely to speak about mental health than we ever were, but we have to have the ways to support them, and it's my hope that we can all do that together.
Thank you.
Good morning. My name is Ryan Spillane. I'm the Chief Financial Officer at Peak Vista Community Health Centers. And on behalf of Dr. Emily Patazik, our President and CEO, who herself is a licensed practicing psychologist, I want to thank you for the proclamation today and the recognition of the important work that so many of us are doing in this community. I had other thoughts in mind, but Dr. Vu, to answer your question, that as I came up to the podium, yes, access is a challenge for everybody at every level. Peak Vista's approach as a safety net healthcare provider is to have truly integrated mental health services in our medical and our dental centers, so that if a need is identified when you're in the dental chair, we have a provider right there at hand who can come in and do an initial assessment and get us directed to the services. So our focus is expanding behavioral health services in the primary care setting. But with the challenges that our community is facing, we're seeing a higher level of acuity and complexity in our own patients. And so sometimes the access is when it's beyond our capabilities to care for. The referrals to specialty services, that is very limited access as well. And then where do they go? So that is just one of a very complex dynamic of access that we see from the primary care environment. And I do believe that reimbursement has a significant impact, but that's a larger discussion with the state specifically. So that more specialty and higher acuity providers are willing and able to provide that services when we're looking for that higher level of service. As part of Peak Vista's commitment to expand behavioral health services, I just wanted to use this forum to thank the county who approved Peak Vista's behavioral health expansion project as an enterprise zone project. So that greatly benefits Peak Vista and our community of donors. Because of the reimbursement challenges, it really is on the philanthropic donor and grant side that we're able to sustain these programs. This year we launched a psychiatric mental health nurse practitioner fellowship, which will bring recently graduated nurse practitioners to a fellowship here in Colorado Springs to work in community health. The first cohort will start in the fall with about 4 nurse practitioners. That will provide an immediate expansion of access for Peak Vista in our community, with hopes that they would stay in the community and love community health in our community and continue to provide services. And that specifically, I want to thank the Colorado Springs Health Foundation for their generous donations that will allow that program to start this year, have all the startup costs fully funded. So there's been no expense from the city or the county or any other government funds to do that. So that's the approach Peak Vista is taking, but to your comment, it is very much on the philanthropic grant and donor side to sustain these programs, which in the long run, we have to consider sustainability. And so I appreciate the proclamation today and your championing of mental health. I would ask that you champion mental health every day. Thank you.
Can I wanted to emphasize that point, Ryan. Thank you for saying that. I want to emphasize, can I ask you a question, Ryan? Because I wanted to emphasize that point. So without donors, if you were to depend on fee-for-service and other direct reimbursement alone for mental health services, can Peak Vista sustain the model that you're doing now?
Can we sustain it? Yes. As a federally qualified health center, the federal government, as a safety net healthcare provider, provides us a stable set of funding. We can't expand to meet the need. I would have to collapse to my core functions, which doesn't meet the need of the community. What we need is expanded access. And so the funds to expand, to grow, and to provide more avenues of access, that would be limited. And if we, the eternal laws of entropy, if you just stay at one size and one capability, you're not meeting the need. We have to grow to expand, and it's going to take all of our partners. It's more than one organization or even one solution can address.
Thank you. I want to emphasize that point. I think we've been talking about mental health issues, behavioral health for years and years, and we haven't solved it. I really think the way to solve it is just some way to solve the entire system of reimbursement.
Any other questions or comments?
Thank you,
Commissioner
Madam
Gonzalez.
Vice. So, one, I appreciate all the comments. This is a significant issue, things we care about. I was on this board when we saw the youth suicide spike several years ago. A lot of initiatives started, a lot of partnerships. Some of them are in here today. So we did see successful implementation and numbers come down. And overall, numbers are too high. I agree. I did want to make sure we're in a room full of professionals. El Paso County is the largest county in the state, so we may lead often. Total number of suicides, somebody mentioned we lead in suicide rate. That's not an accurate statement. I just want to put that. We are doing strong work, good partnerships, doing better. We can do better, but I just want to correct that one statement out there. And we can always improve. And with people out here, we're doing that. And I do believe we're representing and doing a good job for our residents. And we have seen our numbers improve over the last several years. But yes, they are still too high, and we can do better, and we will do better. Thank you.
Thank you. Any other comments from the board? Dr. Chan?
Yes, I have a comment. Thank you. I would like to applaud everybody in the room for the very difficult and complex work that you do. It's a very complex issue. And I would especially like to applaud the mayor's office for recognizing that some of this societal linkages, the personal linkages, and decreasing isolation is a very important aspect of mental health. We can continue to expand services and throw money at the problem, or we can decrease the need. And I think what the mayor envisions is a way to decrease the need for these services.
Thank you. Well said. Okay, I think our next speaker is Kirk Woundy from NAMI.
Thank you, Ms. Ralston, and thanks to all of you for being here today and for putting forth this proclamation. With more and more individuals talking about their mental health challenges, a proclamation like this lets them know that they are heard, they're seen, and their stories don't go unnoticed, and mostly that they are not alone. These feelings of being understood and connected to a larger community can change or even save lives. We see that at NAMI every day. We've been doing this work for about 40 years, starting with family members, and in the last 10 to 12 years, moving to working with individuals who live with mental health conditions. These people come for no-cost education programs, support groups, resource referral services, advocacy services. As you know, the need is not going away. In fact, it is increasing, but so is the collective response to these challenges. And to the extent that you all have the ability and the time to step up and be part of the solution, we just want to say thank you. And just thank you for sending a message of hope to those who are struggling in our community.
Thank you. Okay, I think we have a representative from Diversus.
Hi, good morning, everyone. Kathy McCopoulos with Diversus Health. So Diversus Health has been in our community for almost 150 years, serving those with behavioral health needs. And I wanted to say thank you for this proclamation from our CEO and our board of directors and our officers. Behavioral health is so important in our community. We recognize that. We also have a crisis walk-in center. We work with many community partners, including the police department, the fire department, with our crisis response team, as well as with the Springs Rescue Mission. So I want you all to know that we do have a crisis walk-in center. It's available 24/7 to anybody in the community that needs those services. We also have many programs available, and we have capacity to see additional members that are unmedicated for those services. So thank you again for your support, and we are valuable and more than welcoming to work with any community partner in the organizations that we work with. And thank you all for what you do in the community as well. Thank you.
Thank you. Any questions?
Any questions from anybody? Thank you.
Okay. Are we going to do a photo?
Cass from Suicide Prevention Partner, I see she's coming up.
Good morning. My name is Cass Walton. I'm with Pikes Peak Suicide Prevention Partnership, and I also co-chair the Suicide Prevention Collaborative of El Paso County. I first want to start from a place of gratitude. When you hear proclamations like the one that you all read today, it really is representative of the work that's going on in our community to address this large issue. Sitting in this room with all these amazing people who I work with almost every day makes me feel hopeful. I am lucky enough to work at Pikes Peak Suicide Prevention Partnership and to have benefited from our partnership with public health. Last year we had a youth and family resource navigator who was funded through public health. We were able to engage in a research project called the Teen Think Tanks with help from public health, and we participate in the Healthy Community Collaborative as well as the Youth Suicide Prevention Work Group. Across those community groups, the difference that you're seeing, Councilman Lineweber said, we've never addressed suicide in a serious way. And I disagree with that. We've addressed it in a serious way, but it's been, a single voice maybe, or, something that equals a single voice. The change that we're seeing in our community is the collaboration that's represented here today, talked about in that proclamation, and seen across the efforts, because it's not just the mayor's office or Councilman Lineweber that's talking about the neighborhood gatherings. In the Healthy Community Collaborative, we're talking about how can we go to these neighborhood gatherings and help pass out resources and create increased awareness about what's available in our community. When we talk about what will help people access services more, having different community collaborations that allow us to help people to understand what mental health even is. When we did some surveys of some youth last summer at the Hillside Community Center, it was very clear that many of these young people were experiencing uncomfortable mental health symptoms, but they didn't know that that's what they were. So they didn't even know that they would be candidates for receiving mental health services. And so it's these efforts that are making the difference. It's work that you all are empowering that's making the difference, and I'm just extremely proud and grateful to see the work that's happening. I also, in my work, have the privilege of sitting with families who have lost someone to suicide. And so what I know is that there's still a lot of work to be done, because every week when I sit with a new family who's lost someone to suicide, the words that I hear are, "We had no idea. We knew something was wrong, but we didn't know what to do. We were unsure where to go." And as long as those are the interactions that I'm having, I will be impassioned to help continue all of this collaborative work that's happening, because those are the strongest indicators that we have a lot of work to do. And while I feel optimistic, I also just, as Kirk said, and as everyone has said, this is something that we need to be thinking about every day. Mental health is part of every part of our day, stitched into the fabric of the work that we're doing, regardless of what your profession is. And so thank you for this proclamation, and thank you for the work that you're empowering.
Thank you. Susan? Thank you, Cass, and thank you everyone who spoke, and even if you're in the audience and you didn't speak, here to support mental health awareness. And I wanted just to emphasize what was already communicated, a few pieces. Mental health awareness and what we do for our mental health, whether it's in the workplace or in the community, is every day. Has an impact. And so our board takes mental health awareness very seriously. And I do want to say that the county commissioners, when we were having all of the issues and we were put on the map for teen suicide back in 2014, had stepped up and provided funding, and still providing funding to continue our efforts on teen suicide prevention. And I think that's critical, because today many of our experts have talked about we're making progress. However, we need to keep up the momentum. It's our community's evolving. There are some complex needs, and as a collaborative, and we have numerous collaboratives, multidisciplinary, that we evolve to meet the needs, to seize opportunities for actions. And that's what this group is doing with the support of the Board of Health, but also there's numerous people that are involved in the community, so much passionate work. And there is heavy work from the Child Fatality Review Team that investigates why deaths have happened of ages 17 years of age and younger, and to develop prevention strategies that are effective. And it goes to getting to systems also, but then also there's the individual and what can you do. And we're also working on a behavioral health platform that we're going to launch here probably later in June, and more to come on that. And I know Board of Health, you have information on that. So we are trying from a multifaceted effort with numerous different collaboratives and partnerships to lift up mental health and mental health awareness, because if we're not having good days, and not all of us have good days, and you see some of the data in the proclamation, we're not thriving as we could. So I wanted to emphasize when we entered into the work with the City of Colorado Springs, we were very focused on to lift up the efforts that were already happening, not to come in and say nothing's being done. What is already being done, and how can we strengthen that? And so that's where we're coming from in a strength-based method to seize upon the progress that's already being done and to keep up the momentum. And I too am hopeful because I see the passion, I see what's going on in the community, and I'm incredibly grateful for all of the work that's being accomplished. And you call on people and you want them to be part of an effort. They are there because they are part of the solution. And so I wanted to commend everyone that has a role every single day within mental health, because we are going to keep up the momentum and we are making progress. So thank you so much. And we are going to take a photo. And if you can all come up, and we'll take a photo and then sign the proclamation. So you can sit down or just, Pamela, can you help direct people, please, on what you would like? Anyone who wants to sit down. Because we're going to slam it. We are going to need it. I'm sorry, me? Yes.
Tall people in the back, I've never.
You tell me.
No, how are you? I'm good, how are you? Did you brought your son?
My kids are out of school. So.
I'm in the back usually.
And I like would be driving to Detroit, and we're like, okay, I've got two kids with me.
And then Dave, you want to sit down or?
Actually,
This is my life, and I refuse to pay for a nanny every day. I'm just not going to. I'm just not going to. So. He's got a stack of questions for me already. No?
No, of course not, because it's men.
Well, is she now big enough or not yet?
We think we're there.
We're going to take a 2-minute break to give folks a chance to use the restroom.
Where's Ted?
He's coming back from Hawaii.
Oh, really?
we're ready to get started again, and we have Sarah Kinney, our budget supervisor, to give our finance and budget report.
I'll start again for those online. Good morning, I'm Sarah Kinney, El Paso County Financial Services Budget Supervisor for Public Health. The overall picture for the agency for April remains positive. Walking through some of the key areas, you'll see that our county and state funding revenue continued this month as planned. And you'll notice program-specific grant actuals are running ahead of schedule in a positive direction. And we've added $248K in additional potential revenue for this year's budget. These are all positives for the agency. Licenses and fees are again high this month due to some renewals being annual. We have a little higher volume in first quarter on some of our renewals. Medicaid fees are trending higher, in part due to our team's intentional focus on billing in a timely manner. Public Health received $46K higher in interest, which is due to a combination of higher cash balances in the reserve fund, as well as higher interest rates, ranging from 4.49 to 4.7 received in 2024. If these rates continue, it's expected that we will generate higher interest revenue throughout the year, and this will be another positive revenue for our team. Personnel vacancy savings continued to accrue this month, but I expect these numbers to come in line with our 2024 projections due to the benefit adjustment I mentioned last month, which will be phasing in from May through December with slightly higher benefit costs, and so that adjustment will be coming in. Operating expenditures are running lower than anticipated for this point in the year, which appears to be a timing issue because when I spoke with each of the leads, all areas have executable plans for their operational budgets, so I don't anticipate that we'll have large savings in this area. Capital expenditures trended $56K higher. However, we have ARPA funds, which will be coming in May, which will cover this, so there will not be an issue there. We won't be over in that account. Overall, the agency remains in a strong, positive financial position with a healthy reserve fund. Are there any questions?
Dr. Vu?
Thank you. Thank you, Sarah. It's very encouraging for me to hear that Medicaid fee has increased because of a focus on billing. Two questions. One is there any update on billing for Medicare and other payers? Question number two is the licenses, fees, and permit income has increased. Is that a combination of increase in our fee rate and volume, or one or the other?
I'll start with the Medicaid. So we do have that intentional focus on the billing, which has increased it. We also are training our new Medicaid biller as we're transitioning staff. So that's a positive that we're doing to keep that revenue coming in. With regards to your question last month, we did look throughout the agency, and there are some places where we do have Medicare billing through a third-party provider, specifically in immunizations. And we can provide those details to you by email afterwards with the information.
Okay. That's okay. I don't need the details. I just need to know if we're doing it or not. Sounds like we
Yes,
are.
in some cases we are, sir. Yes.
And Dr. Vu, it's limited. So just the history of this, I mean, our agency hasn't always billed for Medicaid or Medicare as it relates to in some of the clinics. So we are being much more intentional about it, and we have a part-time medical biller who has been very successful in 2023. If you see the revenues that is being generated, we've been very intentional about identifying revenue sources and then training staff or trying to get the capacity or the credentials in order to do so. And so we are doing billing with the Medicare Limited. We hope to try to increase that, but as you know, it's a process. So we are doing some limited billing currently.
Thank you. Thank you.
May I clarify? Are you saying that some of the patients that were being seen had Medicaid or Medicare or another third-party insurance, but they were never being billed through those carriers?
Yes, so I don't know what year it was, but within the last few years, we have been very intentional about billing for third-party payer, but our agency has not had the ability, like when I first started, I've been here for 20 years, that has not always been a practice. Now, I will tell you that at a statewide level, I sit on a funding streams group, and across the state, there are areas where being identified to bill for Medicaid, and some agencies are not billing, some agencies are billing. There's clarification as it relates to if you get grant funding for certain aspects. So a simple answer is yes, previously our agency had not been billing for some of that. Within the last few years, we've really picked up some speed, and especially in 2023, I don't know what the revenue was, but it could have been, I don't know, 700,000 from a part-time biller. I haven't always had the staffing or the credentialing, but we are very intentional about finding revenue sources in order to bill.
Do you know what proportion of services would be subject to third-party billing?
We can look into that and get that information. I don't know off of the top of my head related to all of the different programs that we're providing. I know that there was some legislation that was passed recently that allowed for behavioral health Medicaid billing, but I don't have that off of the top of my head, and we can look into that.
I guess while you're answering questions, what about the savings that are coming from personnel vacancies? Are you anticipating filling more of those positions, or do you think that these vacancies are going to carry forward?
We are doing our best to recruit. I will tell you with specific, like, we have challenges in recruiting. I guess on the topic of a biller, trying to hire a biller, we went out, I don't know how many times, 2 or 3 times, 3 times now, to try to find a qualified candidate. So we are doing our best to recruit and maintain the positions. Nationwide, there have been about a 50% turnover in staffing over the last few years, and trying to build that back is slow and steady. We're watching that every month, and we are trying to work with human resources on being quicker at recruiting, but it's still a challenge. I mean, one area that is very positive is our nursing staff. We couldn't hire. We go out maybe 4 and 5 times for nurses and still wouldn't have a candidate. Now we've been steady with nurses, and so it just depends on the different area. And I will say that we're doing our best. We do still have challenges, and the vacancy savings, we'll have to continue looking for that. And I don't know, Sarah, if you know our vacancies currently, but for this month, I know we had talked about that, but they are running it, like, I would think around 10 or 20%.
Close to that. I'd have to verify the number to be certain, but I can follow up with that.
So Director Whelan, do you think the reasons is it salaries and benefits, or is it a lot of different things that go into why it's harder to recruit?
Salary and benefits is one of the reasons. In the county, we've been doing a lot better. There have been a lot of intentional efforts within the past couple of years, but that is a number one. I guess when we ask staff, or even nationwide surveys, it's the compensation. I will need to dive a little bit deeper into that, but the national surveys and what they're seeing is that public health professionals being harassed, the workload. That's what's been presented in some of the surveys, but I do feel like we're at a different area where I do think that we are going to pick up some speed in 2024. There are going to be certain positions like, the billers that we might not be able to recruit so quickly. But what I'm seeing in our agency is that we've got a lot of new people, whether they've been not even here a year or 2 years or 3 years, and you think about the training that has to be involved in the rebuilding from the past few years and what we've put on pause and to rebuild that. And it's a lot. It takes a lot of work. And I will say in the state of Colorado, there's been about a 50% turnover with staffing, especially in the public health leadership. On our executive team right now, we do have a few vacancies, and also people are on leave, and so we're stretched. And so what happens there is that other people in all the different departments too, you take on the workload. So that's what we're dealing with right now, and I don't know that it's any different from any other organization as it relates to some of the workforce challenges that are being experienced. That's what I'm hearing from the Pikes Peak workforce and some of the leaders that I'm talking with. So I also went to a public health conference recently, and what they had said when what they're doing is providing like a business continuity plan when employees start in public health organizations, meaning that they anticipate that they're staying for 18 months, if that, and then turning over. And so the strategy is to, when you hire an employee, to document all of the tasks, so then if there is a vacancy, so the next person comes in, has a plan forward. And so that was what was discussed at a national conference a couple of weeks ago. So I will say that workforce has been a challenge. It continues to be a challenge. We're doing all we can, and we're also providing mental health services and contracting as well, because there have been lingering impacts as it relates to the past few years and those that are still stuck around. So there's multiple challenges with the workforce.
Thank you. Okay, Councilman Donaldson?
Thanks, Madam Chair. Susan, is it possible for us to see a slide, and I don't know how the rest of the board feels, but for me, it would be useful, a slide of staff and vacancies, like how many are we missing in each of these positions? And something like billing, when it seems to maybe pay for itself, to fill those slots, we were able to capture insurance reimbursements that actually, it goes neutral on that one, that should be a high priority. And I don't know how the rest of the board feels, but I'd like to see, I've seen this in other organizations, you lay it out by position, total authorized, and then are we, -4, how many, and then what's the change been lately? For me, that would be useful. Then we know if we're heading in the right direction or not, rather than hearing about it once a year or less frequently.
Sure, that's very doable. I would ask budget, we can provide that.
Yes, ma'am. We look at those reports on a weekly basis, and we have them available to you on a monthly basis, so it's no problem to present that.
Yeah, and I will say that, one of the strategies that we're focusing on is trying to identify different revenue sources. And what we have been trying to do is hire an additional part-time billing professional. We have a current billing professional who has been very successful, but her husband is military, and so she's vacating that role. And so we're trying to backfill that. But rather than having one part-time biller, we're trying to have an additional one too. So we're looking at that also. But I'd be happy to provide that information, and budget can provide that as part of this report.
Yeah, that would be useful for me. I think other board members would find it interesting to see on a monthly basis, are we heading in the right direction, the wrong direction, or just never filling a certain kind of position? And then maybe we need to change the pay structure for that. So, thanks.
Thank you. Dr. Vu?
I agree with you, Dave. I think that would be helpful, but in addition to that, the other data that would be helpful in my mind also is a graph of turnover rate, and just track that over months. In addition to that, I wanted to ask you, several months ago, General Briggs had mentioned the concept of stay interview, and just wondering if that is still considered or implemented?
Go ahead.
So we just completed a county-wide survey, and we haven't gone over that, but that survey digs into that a little bit, and we have not implemented an agency-wide state interview process. That is something that we have been wanting to do, and I think that those are that's really good information. Why are people staying? And I think that, during one-on-ones, asking people what do they enjoy about their job, why are they staying, what do they need? We're having those conversations, but have we implemented a formal state interview process? We have not done that.
General
Madam
Briggs?
Chair. So to that point, I would say that that's less incumbent upon you and more incumbent upon HR for the county to do something like that so that they get a better idea across the county about why people are staying in their positions, not just here in public health. So not that you want to delegate something like that just randomly, but I think HR should be looking to take on something like that. Thank you.
I'll say too, I know that we work very closely with our Human Resources Department, but I know that they're short-staffed as well. And so that all has an impact as it relates to different departments. And I won't go into much of the detail, but there's a lot happening with workforce and human resources. And I'd be happy to dive into the details later. But I think that with the vacancy rates and with the total numbers, that's very doable to provide on a monthly basis.
Dr. Chan?
I'd like to circle back one more time to the potential uncaptured revenue. I think that perhaps the need for billing personnel might be informed by knowing what percentage of services are actually potentially subject to a third-party bill. Is there right now an avenue where when people come in for their services, they are asked if they have Medicare, Medicaid, or another insurer?
Yes.
Oh, okay, so then it would be possible to know what proportion of services can actually be covered, and therefore how much revenue could possibly be captured, and then therefore how many hours you might need a biller.
Yes.
Okay.
Yes.
Okay. And so right now what you're seeing is that need is only one part-time biller?
So let me provide just a little bit of history with our agency as it relates to budget. So we need to be doing all of these aspects as it relates to what you're talking about related to identifying revenue sources, what's being left on the table, and how do we implement actions to go after that. We only got a full-time budget person recently, and we need help. We need capacity. When we're talking about the environmental health service fees, the bulk of that work we were doing with Sarah wasn't here, and there's capacity issues related to what we need to do and then how quickly we can move on that. So there are efforts that are going to happen as it relates to other areas in our agency. Where do we need to look at the fees to cover the cost, or where can we bill additionally? So all of that is being worked on. It's just a little bit slower than we would like it to be because we have new staff also, and it takes time for them to come up and learn our processes. And there's a lot going on as it relates to some of the grants that are reducing and some of the impacts to the workforce and some of the training. And so it's a huge priority as it relates to generating revenue, covering costs, and maintaining staff. And so everything that you're bringing up is that we are looking at, we need help in order to do that and some time. And what I've talked with President Colas about is doing a work session with the entire board to have a deep dive on the budget as it relates to all of the grants, and to go into detail around like what have we been doing to maintain and to generate revenue, and to dive into that detail in August. Because everything that is being brought up here, we are having discussions on our executive team around all of these different aspects. It's just, it's slower than we would all like.
Thank you. Thank you. Thank you, Sarah, for your informative presentation. We really appreciate the work that you do.
Thank you. And then just to Dr. Vu, you had a second part to your question, sir, regarding whether it's the volume or the specific amount of the fees. And because of the complexity of the fee structure across that whole account, I'd like to provide you a follow-up afterwards with that detail. I don't want to misspeak on environmental services part, so I'm going to confer with them and come back to you.
Thank you, Sarah.
Thank you.
Good job. Okay, now it's Director Whelan's report.
Okay. I think this is probably going to be timely because, one of our number one priorities is to generate revenue and to maintain revenue, and that all goes to maintaining the staff that we need in order to do what we need to be doing and how we're serving the community. And so I had initiated an effort with Dr. Tatiana Bailey, who is she's well known in our community as an economist, but she's also a PhD in public health. So we've embarked on a return on investment for public health services. And part of this effort is when there are efforts at the state to maintain revenue through per capita funding, and in order to talk with our legislators and to help provide the understanding and the value of our services, to put a dollar amount to it. What is that investment? And so Dr. Bailey is going to go over a presentation as it relates to the evaluation of some of our programs and what the value is in the community.
Yes, yeah. Well, thank you very much. I know all of you, well, maybe not all of you, but a lot of you know me in terms of talking about pesky inflation and declines in the working age population. But I do have a public health background too. And in just a couple of sentences, Susan knows this, why I decided to pursue this. As
Ma'am, can you identify yourself?
Sorry.
Please.
Sorry. Tatiana Bailey. I'm a founder and director of, no, that's okay, of Data-Driven Economic Strategies, a nonprofit that we started here locally about a year and a half ago. So just as a very quick background, my parents are both from Bolivia. And when I was a child, I used to travel down there pretty much every year. And Haiti and Bolivia are the two poorest countries in all of Latin America. And I started to see the connection between economics and health. So after I finished my graduate studies in economics, I couldn't let go of that, and I pursued public health. So I'm really appreciative that Susan and I got to know each other, even more so during the pandemic. And then she reached out to talk about some initiatives, and this return on investment analysis is one of them. I'm going to go through the slides, but I also want to highlight not only my gratitude, but also how collaborative this had to be. This is a complex analysis in terms of looking at specifically three of the many things that are done through El Paso County Public Health. Dr. Albanese, Michelle, Sarah, Susan, and several people on her team who really have helped with this. So let me jump in and just give you some quick background context. And this is part of I think it's about a 12-page report that we've put together, and these are sort of the high level. Thank you. Yeah. So I guess I'm speaking to the choir, but just to highlight the magnitude of public health, from 1990 to 1999, life expectancy at birth increased from 47 to 77 years.
mostly attributable to the advancements made in the care of babies and children, as most of us probably know, because for most of human history, high infant and child mortality pulled down the average life expectancy, okay? But we also, complex analyses have shown over the years that interventions that we now sort of take for granted, such as clean water, sanitation systems, vaccinations, early detection of disease, which is all part of public health systems, have been estimated to account for about 25 years of life expectancy improvement. So a large chunk of that 30-year increase over the century, 25 of the 30 years, really attributable to public health. Of course, we also, yes.
I have a question.
I think we both have the same.
Yes.
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 Those dates, is that 1890 or 1990?
Sorry, 1890. It must have been a typo
Okay.
that I didn't even recognize. Yes. All right. And then we also know that public health is centered around the prevention of disease. But we also know that healthcare in the U.S. follows a highly curative model, which is very costly. 75% of healthcare dollars in the U.S. are spent on treating disease, while only 3% are spent on disease prevention. And I think we all know that that's also a missed opportunity. And even after the height of the pandemic in 2021, the U.S. spent $4.3 trillion on healthcare, but only 4.4%, or $189 billion, went to public health and prevention, including disaster preparedness. Yet public health expenditures are decreasing in real or inflation-adjusted dollars. You can see on the chart there that the CDC budget is down from 2010 levels after adjusting for inflation. Congress has cut the CDC's public health emergency preparedness funding for states and local areas by half since fiscal year 2003 after adjusting for inflation. And then another arm, the Healthcare Readiness and Recovery Program, administered by DHHS for public health emergencies and natural disasters, went from $515 million in 2003 to $305 million in 2023, a 2/3 cut after adjusting for inflation. So definitely a continued trend even in light of a public health emergency. And then addressing workforce shortages, which I was keenly listening to, despite population increase, state and local public health agencies have lost 15% of their workforce over the past decade. And really good study that I found from the Development Foundation said that we need to hire at least 80,000 additional full-time positions to establish an adequate workforce to deliver minimum public health services. And of those total positions, about 54,000 are needed at local health departments. A separate study found that 56,000 local health department jobs had been eliminated since 2008 due to the funding cuts. So, of course, the great financial crisis had a part in those reductions as well. Nearly half of all employees in state and local public health agencies exited their jobs. So this is addressing exactly I think you said 50% turnover that we've seen here locally. Reasons include harassment of public health workers, retirements, and other departure reasons. The same study found that nearly half of the workforce plan to leave their job or organization by 2022 due to inadequate pay, lack of support, lack of advancement, or workplace environment, pay being the number one. And then, you know, all of this lack of prevention and the workforce issues translates to higher overall healthcare expenditures. I think probably everybody in the room knows that we spend about double the OECD average of other developed nations in the U.S. This is 2021 dollars here. In 2021, this year, we spent 18% of GDP on healthcare, whereas comparable countries spend about 11% of GDP, according to the Kaiser Family Foundation. But then the outcomes, unfortunately, don't match those increased expenditures. You can see the blue line shows the comparable country average, which did take a little bit of a hit during the pandemic. But then you can see the U.S. has consistently been below that, and the gap has actually been increasing. And then, of course, that was further exacerbated by the pandemic. I want to mention that the comparable country average in 2014 for life expectancy was 82.2, which was 2.3 years higher than the U.S. So why is public health so undervalued? There's a myriad of reasons, but it's inherently very difficult to measure the benefits of prevention, right? What has not happened. True comparison groups, like eliminating free childhood vaccination in underserved regions, would be considered unethical. I mean, how would you have a real comparison group because of, the outcomes that would be associated with that? The benefits of population-level public health interventions accrue over a very long period of time, and humans often discount what's actually happening in the future versus what's happening today, and that helps explain the highly curative model that we have today. And then the average person, households, and even policymakers are not always fully aware of the benefits at the individual or aggregate level in terms of the advantages of public health programming. So, a quote that maybe a lot of us have heard, the challenge facing public health systems is that public health interventions are successful only when misfortunes do not happen. So, this is part of the rationale for this return on investment analysis. And, we looked at the long list of services that are provided by public health and really narrowed in on 3. Mostly because of data availability, the ability for the common person to understand what these interventions are, and so forth. And digging in to some of the literature, this can help really quantify, right, the public health expenditures relative to the costs. Lots of studies have been done over the years, but there's a systematic meta-analysis that was conducted in 2017, which is kind of considered the gold standard for return on investment analyses. They did a huge sweep of the literature, Medline, Embase, PubMed, and so forth, and looked at, it was close to about 3,000 different studies that have been conducted over the years, and looked at both return on investment and cost-benefit analyses, and they are, correlated, those two numbers, of high-income countries. And those ratios were used for 2 out of the 3 services that El Paso County Public Health provides that we included in this analysis. So 2,957 titles. After the specific criteria that they used, 52 were identified as qualified and were included in the meta-analysis. The National Institute for Healthcare Excellence criteria were applied, the NICE, if you will, criteria. And of those 52 studies, 29 were public health interventions. And all of the studies had varying time horizons, 10 years, 15 years, although most of them were several decades long or over a, quote, lifetime. So pretty comprehensive. The study also calculated the median ROI and found that for all public health interventions, and found that for every $1 invested in public health, $14.30 is returned to individuals and communities. And that's across all of the studies that were included in this particular meta-analysis. Now, for context, so that's 1 to 14.3, a good return on investment for finance and econ people is in the 5 to 7% range, so the ratio of 1 to 5 or 1 to 7. But an ROI of 10 or more is considered a, quote, great investment. Not surprisingly, the ROIs and cost-benefit ratios varied greatly by intervention. And, somewhat intuitively, the interventions that focused more on health protection and legislative interventions yielded the highest ROIs, often because they're one-off events, like one vaccination or, a 2-dose vaccination or a new taxation policy, because there's kind of a lot of work that goes into that, but then the benefits accrue over a very long period of time with not that many touch points. And then some of the other interventions that had lower ROIs are still considered great interventions, but they have more touch points, so they, quote, cost more. All right, so in applying that overall ROI to what El Paso County Public Health does, we looked at the pre-pandemic expenditures in 2019, according to the budget office here, and found that $17 million was spent on personnel and operations related to the provision of services for county residents. And of course, we used a pre-pandemic year to avoid funding and service distortions. Less than a quarter of those budgeted dollars emanate from El Paso County taxpayer dollars. So, you know, the contributions from other funding sources, such as grants, really enable public health to provide all of its core services. So if we apply that median ROI, the return on investment for every dollar put in to El Paso County Public Health, residents in the community yield a benefit of $244 million, and this is per year in 2019. And then we also, said, okay, well, let's step back for a second. If we're going to communicate this high ROI, let's talk a little bit about what some of the services are that are provided. What is El Paso County Public Health providing in the community? Well, we know that the benefits include lower disease burden for children who are vaccinated, the higher academic performance and better career trajectories, fewer sick days, and higher worker productivity for parents. Lower disease burden for adults who are vaccinated or who get early diagnosis for treatable diseases, fewer sick disability days, and higher worker productivity for the adults who are, have these services provided, higher quality of life, typically measured as QALYs, and then prevention of associated community-wide disease outbreaks, of course, as well, and that's sort of due to herd immunity. Lower incidence of retail foodborne illnesses, lower incidence of waterborne illnesses, other preventive and education services such as childhood nutrition and developmental counseling, issuance of birth and death certificates, environmental interventions which help lower the incidence and prevalence of respiratory related diseases, through the monitoring that the county does, and then also care coordination, helping populations without health insurance and without the knowledge how to navigate our complex U.S. healthcare system. And through another initiative with El Paso County Public Health, the Partner Engagement Grant, really, I learned a lot more about the care coordinators that are now part of the county and county public health, and the incredible work that they're doing, and how, if anything, the need is increasing, and mental health is, of course, a big part of that. And then, all of this also ties into the public health legislation that I know Director Whelan and others work on as well, around health promotion that can enable all of these initiatives. And then this is in the final report, and I know it's too small, but it does show all of the different departments and services. And I know a final report is going to be made available to everyone, who requests it as well. So when we then stepped back and we looked at the interventions, one of them was MMR and MMRV, including varicella vaccinations. We looked at how many vaccinations were administered, and also looked at 2019. And the savings, of course, really primarily emanate from inpatient and outpatient healthcare cost savings at the time of exposure and manifestation of the disease, as well as the long-term health consequences, the work absenteeism and lost productivity for parents or adults, and then the lower disease burden, right, from the herd immunity. In 2019, there were 516 MMR vaccines administered by El Paso County Public Health, and an additional 275 MMRV vaccines, and those are single doses. And with the help of Dr. Albanese, we were able to make the assumption that even with that one dose, we can make the assumption that either that is that second dose, because it's a 2-dose regimen, or that a child or even an adult would get benefit downstream, because 91% of El Paso County children have had both doses by the time they finish K-12. So looking at all of that, in 2019, we estimated that El Paso County residents derived $1.5 million in financial benefit from a $113,000 investment in these 2 vaccinations. And that ROI comes to, for every dollar invested, there's $13.58 in financial benefit. A similar study was done for
Madam
WIC.
Chair.
Yes.
Can I ask one question right there?
Sure.
But that assumes every one of those children would have gotten disease if they hadn't received the vaccine, correct?
No, that's not how that works. Mm-mm. No, this is actually an analysis that looks at the sort of almost like side-by-side comparison, disease versus non-disease. So it's looking at all of these cost savings that are listed here in association with the vaccination.
I'll hold till you finish.
Okay.
Up, maybe we'll come back to it.
Okay. And then for women, infant, and children, we did also the 2019 analysis and looked at the benefits of supplemental nutrition provided by El Paso County Public Health. We did not include the breastfeeding support in this. And the savings come from pregnancies that go to term, fewer premature births, lower incidence of low or very low weight infants, fewer infant deaths, and other positive externalities associated with receiving prenatal care. In 2019, 23,171 pregnant women and children up to age 5 received WIC benefits through El Paso County Public Health. So if we take what is being done here locally and apply the ROI, El Paso County residents derived an $8.12 million benefit, financial benefit from the $3.27 million invested in WIC. And that ROI translates for every dollar put in, $2.48 is derived in financial benefit. And then the last one we did was retail food safety inspection. I think all of us, can also associate with just the food safety at grocery stores, food trucks, restaurants, and so forth. And the list is up in the top bullet there of where this food safety inspection occurs through the county. And then we used a USDA study on cost per case. And that is $2,386, and extrapolated the incidence in the U.S. from this USDA study to El Paso County Public Health and applied those numbers. And that came to 1,084 known cases of foodborne illness. Now, we know that this is likely very underestimated. Probably everyone in this room at some point has gotten sick from food, but not necessarily gone and gotten tested or treated and so forth, or sought any type of care. So we know that it's an understatement from that perspective. But we also know that it's not an exact science because what El Paso County Public Health provides in the food safety is part of an entire food chain. And I think that's my next slide here that we have in the report. So, for instance, in transport and so forth, there can be things that happen in terms of food safety, but it's not necessarily going to be captured. So this is not an exact science here per se, but it does give us a sense. With the help of Dr. Albanese, we might be going back and revisiting some of these numbers because the primary illnesses that are associated with unsafe food have multipliers. And we might be able to turn around and actually apply some of those multipliers to the diseases, which is probably going to be a little bit more accurate. But for now, even with this conservative estimate, we found that there were 2,804 inspections and re-inspections. In 2023, we were able to use the more recent data. And that ROI came to $3 million in financial benefit for El Paso County from a $2.4 million investment in the retail food inspection program. And that translates to, for every dollar invested, there's $1.27 in financial benefit. And then that was the food chain, just a very simple picture. And then this is just a summary table of the results that I just went over on each slide. Also, of course, in the final report. And then the last thing was, what are next steps with this? And, so we can leverage this information to help raise awareness in what public health does in our community. I do weekly Fox 21 segments, and I often include very specific information on our
some things, good things that are happening in our community, and I would recommend having 1 or 2 segments on that. I would love to actually have one of the care coordinators and a client be part of one of those segments, just to highlight some of the benefits that the community is deriving from the work. I always make those into articles. I never thought anybody watched local news, but I think that this gets more traction than I would have realized. So it's one way, and then I know I'll be partnering with Susan as well in terms of some other community events where we can talk a little bit more in presenting these results. Possibly a submission to an academic journal, social media messaging, simplified infographic for easy distribution. And then Susan and I have also talked about perhaps additional ROI analyses in the future or technical assistance with some ongoing evaluation endeavors if it's deemed beneficial. So that's the end of the presentation. Thank you for listening to that, but I'm also open to any questions.
Okay. Questions for Dr. Bailey? Dr. Vu?
Wow. So much information. I have so many questions on my mind, and I don't think I can ask them all, but I have one question. But before that, Dr. Bailey, I wanted to thank you so much, and I don't have the words to describe it, but thank you. The ROI for public health is 1 to 14.3. That's very good, I think that's the term. Would you happen to know what the ROI for investment in primary care in general in the U.S.?
No, that's a great question. I mean, I honestly didn't look at that specifically, but I feel like I became kind of an expert on how to dig on finding these analyses. I'd be happy to look, just do a search for you and see if that's been. I don't think it was part of this meta-analysis. These were pretty specific services that are provided in the community.
Yes, thank you. That would be very helpful.
Yeah.
General Briggs?
Yeah, General Briggs. This may be a question for Susan, but both of you referenced, I got to read it, harassment of public health workers. Can you tell me what that's about?
So I'll start. I mean, there was a national survey by the de Beaumont Foundation that revealed this information. I can only speak from experience at the local level, and I don't want to go into too deep to. I'm not going to go too deep into that, but I will tell you that what we experienced, my staff, as it relates to going through the pandemic. Being accused of killing people and people's loved ones. Some of my staff are hired to work with moms and babies. When you get hired on at our agency, we all have the responsibility to be trained as first responders in the National Incident Management System. And when a situation arises, we scale up or scale down and we fall into incident command system. And so we have to fulfill different job responsibilities, and you're given certain jobs as it relates to what the emergency requires. And so some of our staff that were hired on to work with, maybe moms and babies, and this is just one example, had to work in different institutions where there were regulations or mandates coming down from the state, which required us to take action on certain different efforts, and very different roles than what some of our staff are hired to do. And so I know from the public and hearing from my staff that they were accused of killing loved ones, when that's the exact opposite of what the role that we provide. We were, and this is just like, there's a lot to unpack here. Some of my staff, and this is hard for me to talk about, but we're told if we show up, we'll end up going away in body bags. I'm sorry.
So maybe, just to sort of pause on this. So is this more related to the pandemic, or was this something that you saw before the pandemic? Because the pandemic sort of amplified all
My-
kinds of
my
weird
ex-
things.
My experience is that we had a high amount of credibility and respect before the pandemic. We used to run investigations just very, very credible, very workable. It was a very different operation. Pandemic came, and there were so many different aspects of what occurred. And I will tell you that all of my staff that have been involved have their own personal stories as it relates to what that involves in. And so, as you can imagine, trauma is trauma. And you don't just shake that off. Part of the reasons why we put in the additional contracts for the Resilience Center is to offer assistance for my staff to go and, or for their family members, because it had huge impacts and huge family sacrifice as it relates to some of the requirements. And so that doesn't just get shaken off. And so the survey wasn't done in 2023 or 2024. There is another effort from the De Beaumont Foundation to take another survey. But yes, there has been a lot of harassment, and it has been a different, it's been different working relationships pre-pandemic and after the pandemic. I will say in large part, we have extremely positive relationships, professional relationships and collaborations, and we have a high or a tremendous amount of respect and credibility from the community. But that has an impact, and I will tell you that, many of the folks that I've worked with for years told me, Susan, I got to go. This is not for me, and I respect that. And I still see some of our staff burnt out from what has happened previously. So it has had a huge impact. It will continue to have an impact, and we're working through that as it relates to the workforce. But we have lost. It's just a different. It's a different time. So hopefully that's helpful.
It's disturbing but helpful. And obviously, this board's has an oversight role, but we also have an advocacy role, and we'll continue to advocate for the staff and what they do, because we see it up close and personal what they're challenged with, but also what they're doing. So, thank you for sharing that, and also for the intensity of how much you care. I appreciate that.
General Briggs, there were a couple of articles. I believe this is the one, though, and if you wanted to take a picture of it, that has the results of that survey, if you wanted more specifics.
Any other questions or comments for Dr. Bailey?
I do. Well, go ahead.
No, go
Doc.
ahead.
No,
You go.
Go ahead, Doctor.
Dr. Chan?
I don't know who this would be a question for, but I think what I'm trying to understand is, in terms of El Paso County public health, are the bulk of expenditures in programs that have a higher return on investment, or is the bulk in programs that have the lower return on investment?
It's a mix. It really is. As I mentioned early on in looking at the meta-analysis, the table that shows the cost-benefit ratios or the ROI, some of them were, relatively small, and other ones were huge. And so much of it does depend on how many touch points there are. But also, how long does the benefit accrue? Is it over a lifetime and so forth? So it really does vary, and that median of, for every dollar spent, $14.30 are returned, is taking literally the midpoint of all of these different, ROIs. El Paso County Public Health is representative of other public health agencies, so it is an extrapolation. But we have not done an ROI analysis on every single service that is provided by the county to be able to say, Is the preponderance, below 1 to 5? And, that ratio, we wouldn't know.
I guess along the same line, have you seen any service that would have negative ROI?
I have not. And I didn't see any of that in the literature as well. But I mean, that's a fair question. A lot of times, if you do have something like that, you would hope that that would go away, so to speak.
I misspoke, I mean less than 1.
Okay.
Councilman Donaldson?
Thank you, Madam Chair. Everything has diminishing returns, right? Or almost everything has diminishing returns. But what you're postulating here is that for every dollar we put in, we're going to get 14.3 back. But at some point, the curve bends and it starts going down and you don't get that back. Has that been looked at?
Yeah, so as I mentioned early on in the meta-analysis, they have in the table, and I'd be happy to share that report with you, what is the time horizon for each of these. And in most cases, it was a long time. Because when you think about it, when you're averting disease, yes, you're right about almost everything has diminishing returns, but this is an interesting case because if you have averted disease, let's say in childhood, you're going to have benefits then, right, with academic performance and so forth. But then you're also going to have a better career trajectory, quite possibly. And then you're going to be possibly making more money and further educational attainment and a longer work life and greater worker productivity. So it does vary, but what the studies try to do, if they say, hey, this looked at a quote lifetime or 50 years or whatever the case may be, it's looking at the totality of that, probably with, some fluctuation within a given lifetime.
But what I'm looking at is if we have $14.1 million going to this public health agency, I think it's a mistake to say, hey, if we double that, we'll get exactly the same ROI out of it. Because, for example, restaurant inspections, we may be inspecting all the restaurants now and doing the proper amount, doing a great job. Any dollars added to that doesn't get us better results. It's just additional cost. Has that been looked at? That kind of, okay, where are we? Which of these things would it make sense to have additional funding for and which ones not? Because the way it's presented right now, it just seems intuitively like, well, put more in there and we're going to get $14 back every dollar we put in.
Yeah, I mean, I don't see anything that we've put together or in other analyses that say, okay, well, that means that you should triple the funding. I don't think that's the takeaway from it. Just like, why do we have double the expenditures in the U.S. For healthcare? It's not necessarily getting us better outcomes. In fact, our life expectancy is lower in the U.S. So I don't think that we would want to make that assumption at all. I think the idea is if you invest in public health, particularly preventive care, which is what a lot of public health is about, you are reducing expenditures downstream and typically for a very long period of time.
And I think the most important thing that you're pointing out is some things have a much bigger return than others. A clean water supply prevents all kinds of problems in our society. Mm-hmm. But there are other things which public health may be tempted to get into that are going to give us a much lower return on investment. It may even have unintended consequences and distract us from these core functions that we should be doing, and there's a big return on investment. So I would be interested in information on that, and also those points where you hit diminishing returns. And we're probably there on some things, and maybe there are some things where we could invest additional funds and get a better return even. So thank you for the presentation. Things like this always make me nervous because they can be misinterpreted or used for they can confuse people. So, but thank you for the information.
Yeah, I will say this. I think it's really important to highlight the flip side of that as well. In other words, to say a lot of people don't even realize what the benefits are. So why don't we at least take a point in time, 2019, 2023, look at a small sample of what public health does, and then be able to translate it into what is the benefit, not just in a given year, but again, over a long period of time. And even for those interventions that have relatively low ROIs, anything that's positive, by definition means that you're getting more than what you're putting into it. And a lot of the ones that do have a lot lower ROI have multiple touch points, like the women, infant, and children nutritional counseling and so forth. And, but we know that the outcomes of that can accrue again for decades for the children, and certainly, in a shorter period of time for the mothers. So we wouldn't want to, I don't know that we would necessarily want to say a lower ROI means maybe we shouldn't be doing it. I think it's just a matter of, is it positive? Does it bring benefit to the community? Is it synergistic with the other health services that are being provided, public and private, across the state and certainly within our region, and build on it from that perspective? What are the positive externalities that are coming with this work?
Yeah, and Dr. Chan asked this question. I mean, what we, as a board, probably need to know is, where is El Paso County Public Health spending the dollars, right? Out of that 14.1 million, where does it go? Which programs is it going into? And we don't have time to go into this, but what are the assumptions we're making? Like, based on the numbers that were up there for the MMR, each injection's $150 or each treatment, and we're assuming somehow we're getting $2,000 of ROI on that. But what are the assumptions that it's preventing? How many cases of disease is it preventing? And without that, it's just it's difficult to understand how those numbers are derived for me. Like, where do we get the
No, I'd be
ROI?
happy to go over that with you, and I could also send you, how the methodology of how these are calculated. It is basically, this is a financial analysis, right? That's looking at what are the cost savings associated with the lower disease burden.
Yeah, but it all
Inpatient,
depends on how
outpatient,
many
and so forth.
cases of disease you prevent.
Oh, that's-
And how do they get those assumptions or
It's all
numbers
based
which
on
they use?
incidence, but I would be happy, I'd be
Okay.
happy to give that. Yeah, we could take this one step further and say, try to estimate how many people would be sick if this didn't occur. That's not an easy thing to do. But I think it makes more sense to look at all of the different studies that have been done on incidence and apply those. And that's typically what you do in an ROI analysis. But I am happy to share, and the final report has a lot of footnotes, so it's pretty easy to, just click on the footnote, on, the references, and go directly to the study. Any other questions?
Dr. Chan?
Are there any public health interventions that are currently severely underfunded or not funded that would have a good ROI that you might want to take either to the state or look for grant funding?
Well, embarking on this ROI, this is the first type of report where we're really digging in to understand it better. And this, we haven't thoroughly discussed it as an executive team and see where we take it as it relates to your question. We do know that we're the largest populated county. The needs continue to increase. Back in 2019, we had about $17 million as kind of a steady in our budget. We had 158 FTE. Pandemic happened, we increased some of that funding and about doubled that. And we've been on the downward of that, and also with the American Rescue Plan Act that are going to expire in 2024. So that's, we've been managing some of that, and we are at, I think it's 196 FTE currently, and back in 2018 when we had that the recession, we had 251 FTEs. And I wanted just to give it a little bit of history related to the FTEs and the budget. And so we're on the downward. What we are doing currently is being very aggressive as it relates to seeking grant funding to fund our services. And, some of the areas that we've been trying to target more are recently the impaired driving. I know that's been, as issues come up in El Paso County or Colorado Springs, that's where we try to go after some of the grant funding. Recently, we put in a grant with the Health and Human Services to partner with the Lyda Hill Center and to maintain our care coordinator. So a lot of what the funding that we are going after is not necessarily at this point saying this is going to yield, we know that this is going to yield a return on investment of X dollars. It's more about what is the data, what is the need in the community, and what do we have capacity to do, and how can we partner to do some of that, because we know as the most populated county, the staffing is very stretched, and it's not where it needs to be. So with this study, what our hope is to do is to take this information and discuss like what does make sense. So this hasn't been done before with our agency, and so this is the start of like on that return on investment, all of the questions that you all are asking, like what makes sense as it relates to maintaining funding for the services, seeking additional funding, and then having clarity around that, and then working with our state legislators or locally also to maintain our county funding and to ensure that we're providing a value and demonstrating that there is a return on investment, whether it's a dollar amount that we can state or if there's data that we can demonstrate that is making a difference.
Dr. Vu?
Can I have an opinion? So if we look at return on investment alone, in my mind, any service that has a return on investment greater than 1-to-1 is underfunded if we look at ROI alone. So.
Commissioner Gonzalez?
Oh, thank you. So, and I don't know if I missed this or not, but so you've listed 3 examples. How many total were looked at in terms of ROI analysis?
We only did 3 for the county, to get started, so to speak. And if there's interest in going further, I mean, we've even talked to Dr. Chan's question. I mean, the care coordinators through some other the partner engagement grant, the value of helping individuals who are uninsured or who just don't know how to navigate the healthcare system in and of itself, of course, has another huge benefit. But yeah, no, this is a small subsample.
So my question, so on page 33, so all 3 examples are under 14. The significant, you can go to slide 33, please.
Mm-hmm.
All are under 14. The biggest numbers are the ones that are at 1 and 2. So how is there an aggregate of 14 when all the examples are less than 14?
Well, the vaccinations are very close, but that part of the reason we did WIC is a lot of people are familiar with it, and the retail food inspections as well. But we also know that that's a lot of touch points.
No.
So that's why the ROI is typically lower.
Right. No. So the 3 examples are all less than $14. You have an aggregate that says the return on investment is 14. How can? how can the aggregate be above
Because the three.
mathematically the
Yeah, no,
others?
no, because the three are just a small subsample.
That's
of-
why-
of-
but you-
Of the various services. So we're not saying it adds up to the 14.3. If there was an ROI analysis done for every single thing that, that El Paso County Public Health does, you know, according to other studies, we'd come to the ballpark of the 14.3. But, you know, there's also a recognition that there are underestimates here, too. So, for instance, for the retail food inspections, there's so much underreporting that goes into, you know, that is a result of really just the inherent nature of foodborne illness. And as I mentioned, we may be going back and applying multipliers in talking with the USDA and Dr. Albanese. So that is the lowest, but I'm not convinced that it's necessarily
I don't think you understand the
representative.
question, so I apologize for that
Okay,
aspect.
go ahead.
Commissioner, let me, Dr. Albanese, co-medical director, let me try to, I think I understand your question. So the data, there's two different data sources for these estimates.
Thank you.
Right, so.
Please explain that.
So
Thank-
the bottom table is from the, sort of the aggregate analysis and return on investment studies in the literature that came up with a figure, an average figure across the board. This is for U.S. public health programs. That's one number. To apply that as an example, and please, Tatiana, correct me if I'm wrong, to apply that as an example for some of our work at the health department, we then dug in with three specific types of programs, just as an example to give something that might feel a little more interpretable and tangible, thank you, for El Paso County. So they're not necessarily direct comparison. It's, yeah, it's you know, the bottom row of the table is sort of this aggregate number from the literature, and then the other three are specific examples to
Right,
evaluate.
and
the
so,
health warrant.
right, and so what exactly. So two different sources of data, got it. So what we'd like to identify are the ones that are, clearly, if on our examples, the $13 on return is 100,000, and the 2.4 and the 1.27, which are lower ROIs, are almost $6 million, a third of the, those would really bring down that average, that 14 average would be down. So we have to identify the ones that are at 15, 18, 20. I mean, there's got to be some that are much higher than the 14 to compensate for the 6 million at $1 and $2 return on investment. And that, if we can identify that, that is potentially a great place to where we should be, potentially, because we don't know what the, you know, the long-term effects are. But that's, so thank you, but you
Yeah,
clarified it.
And I did mention the, you know, taking the median ROI from this meta-analysis that included almost 3,000 studies. But I'm moving quickly through this. But I think there are two additional things to answer your question. One is, if we're going to be totally comprehensive on this, right, we would have to look at every single ROI. And there are some that I'm sure are going to be much higher. I do tend to go conservative, honestly, on my estimates. But I also think there's another dimension to this in terms of what is being provided in the community already that maybe, and what are the gaps in that. So part of what public health does is help close some of those gaps for either people who are uninsured or don't have as much access, need some additional, you know, that's back to the synergistic question. So that's another consideration, because this is a financial look at it. It has its place, but it also doesn't answer the question of what is the overarching value that can be provided that is not necessarily easily provided, you know, through other mechanisms in the community and in healthcare delivery. So I think that's another important thing, and above and beyond the financial.
Was this study based on the British healthcare system or a U.S. healthcare system?
It's actually developed countries. That was something that I had in one of the earlier slides as well. Yes.
Could you send us the actual?
Sure.
The actual study, because I can't seem to access it online.
Yeah, I actually have, I'm pretty sure I included the.
Yes, you included the reference, and I just looked it up, but I can't access it.
So might I suggest that we
There it is.
invite Dr. Bailey back another time, especially if we can get copies of the slides and the information, because it'd be really informative. I think we're all really interested in this topic. You've done amazing work on this. It's very detailed, and it's almost overwhelming for me. It's just to get it all at once.
I
So
think,
would
also
you
the-
like that? Would that be good, to have her come back?
Yeah, and the final report, too. There's the source listed there for that study.
I just looked at that source, and I cannot access the paper, so.
Okay,
could
it
you-
is free, so
Yeah.
maybe.
Maybe I need to look somewhere else, but.
Yeah.
If we can get
I can
provided
probably
this,
send it to you.
this, so we don't have to hunt for it, that would be great.
Yeah. that'd be
Yeah.
good. Thank you.
Okay. Any other questions?
Could, one last, just observation. To go back to my favorite, the MMR, once you've immunized all the children, you're done, no matter what the ROI is. So you can't keep doing it. Dr. Vu brought up the point that, hey, until you drive that ROI down to 1, we should keep putting money in there. But once you've immunized all of them, you're done. Once you've inspected all the restaurants, you're done.
But there's always more
there's a
children.
There's always more
benefit.
children.
But what Dave is saying is if you triple the expenditure, you won't get the same ROI of 13.58, right? It might be 2 point something, it might be 6 point something. And if you multiply by 10, you might get an ROI of less than 1 to 1, is what Dave's saying.
That's right, and I am aware that children are born. That's not what I'm pointing out. What I'm pointing out is that like with restaurants, more restaurants will be created, but once you've inspected all of them, you can't keep pushing the ROI down. So that's all.
It's a point in time analysis, right? And not only are more children born, but also you have a lifetime of benefit that accrues. So you might be vaccinating that child twice by the time, they hit kindergarten, but you're going to have a lifetime of benefits associated with not having the disease.
I'm a talker, but a disease such as strep throat or pick a disease, not all of them have lifelong consequences if you suffer that disease. So not all diseases can you look, hey, when you're 80, it'll have benefited you this way. You will have gotten your case of poison ivy or poison oak, and then you got over it, and then life goes on. Some do have lifelong consequences. Those would certainly be more important to focus on. So, thank you.
Yep.
So thank you so much again. I really appreciate it, and I think that we've learned a lot, and we have lots of questions, so we'll learn a lot more the next time. Thank you. Any other business? If not, I'd like to have a motion to adjourn. And also, before that, just want the Health Department staff and Director Wheelan to know how much we appreciate the work that they do each and every day for the benefit of our community as a whole. We couldn't be as healthy as we are without you, so thank you. And then also have a safe and healthy Memorial Day weekend. So motion to adjourn?
So moved?
Second.
All in favor?
Aye.
Aye.
Thank you. Meeting's adjourned.